In the U.S., those groups leading the way include the Institute of Medicine, the National Institutes of Health, the Centers for Disease Control and Prevention, our Agency for Healthcare Research and Quality. In Canada, the Canadian Institutes for Health Research also are doing much to try to address this, what they call the evidence to action gap. What then do we know about the factors that influence the uptake of evidence? When you think about this, there seem to be three parallel literatures and researchers. One is the clinical translation literature. And here in the words of the IOM, the Institutes of Medicine Roundtable, when they talk about translation, they talk about T1, which is the translation of basic science research to new therapies, T2, which is the adoption of new therapies into clinical practice. Others have taken to using the terms T3 for how this then spreads into the community, and translation step 4, the influence on policy. At the same time, there is a very long tradition within the political science community of looking at factors that influence translation of evidence to policy. From this literature, we're aware of the idea of policy windows, which are opportunities in which change is considered not only possible, but usually urgent. What often has in the past precipitated these policy windows are critical events. At Hopkins, for example, it was the death of a child through a medical error that really increased our awareness, our concern about our failure to take evidence more into consideration in our clinical processes. Most recently in the US, it was a giant storm that exposed very vividly the risks that we are undertaking in not taking more seriously the evidence on climate change and increasing our preparedness. But often, in our time, there is increasing evidence on data, and policy windows are sometimes created from new data. I think most recently, both in the US and in the European region, new data on the size of disparities in health status, health outcomes, and quality-adjusted life years. There is a third tradition also within sociology, and that is a very rich literature on the adoption and diffusion of innovations. And I think that literature can be very helpful in trying to, in increasing our understanding of how we can achieve consensus on a path going forward. Sometimes, I think there are lots of good examples of this, we are willing to work together to go forward if it's done on a pilot basis. We say, let's experiment. Let's not adopt wholesale change. Let's use an incremental approach with built-in evaluation. So there are actually many similarities across these literatures regarding the factors associated with the translation of evidence to action. All of this or where we are now, basically, has generated increasing evidence in what we are calling implementation science. And I'm defining it here as the study of methods to improve the translation of research findings, including their uptake, their adoption, and implementation into policies, programs, and routine practice. The objectives of implementation science are to close the no-do or evidence-to-practice gap. And I'd like to give as one example of this PEPFAR's embrace of the implementation science framework. And I'd like to just spend a minute describing that. PEPFAR is the U.S. President's emergency plan for AIDS relief. And they work with implementing organizations, a lot of NGOs, and also governments in over 32 countries. In its first phase, which I should have included on this slide, PEPFAR focused on the HIV/AIDS crisis, and their actions they felt were needed on an emergency basis. So this was action, but the emphasis was on doing, not so much on evaluating and trying to understand more deeply what works. In its second phase, PEPFAR is emphasizing sustainability, with the idea that programs must demonstrate value. This goes to our first presentation, and impact to be prioritized within complex and increasingly resource-constrained environments. So their approach, this second phase, focuses on three phases of implementation science. One is monitoring and program evaluation. Is the program being implemented as designed, and are the benefits actually getting to intended recipients? A second is operations research. What are the implementation problems and possible solutions? Can efficiencies be improved? Most importantly, what is the optimal allocation of resources? And finally, impact evaluation. What is the impact on beneficiaries? What affects variation in impact? Can best practices be identified, sustained, and spread? And I should have added here, increasingly, what are the costs of implementation? And what is the return on investment of these costs? So in summary, where we have been, I think, is this area of evidence creation. First knowledge generation, then synthesis, then knowledge application tools. We've had an understanding that there are external factors and internal factors that create facilitators and barriers. But I think there has been an assumption that once this is done, once we convert knowledge into actionable guidelines, the rest would follow. And I think what we are learning is that really doesn't happen for all kinds of reasons, and we've talked about several of those, and I hope more will be discussed shortly. So what then is implementation science? That is over here with an emphasis both within the clinical practice, the public health program, and the public health policy arena. The emphasis is on translating the evidence into action, but then evaluating the impact of those actions and feeding back those evaluation results into this process to strengthen it. So, in conclusion, how can we build stronger bridges across the evidence to action gap? I think many of us feel like this traveler here in trying to bridge that gap. There are 4 thoughts I have about this, about how this might be done at the EU level, and they're based on my experiences in the US with health insurance reform. There we have, although the federal level can give guidance, can pass laws, it's really the states who regulate insurance. So how to bring states together over these issues has been a huge priority. So I think there are four thoughts. One is bringing researchers, policymakers, and other stakeholders together in forums like this one and in other types of working groups. Two is identifying best practices and spreading awareness. What works and why? How can an approach be customized for other settings? Three is sponsoring pilot projects that will help us become more aware of the options for implementation. And four is helping achieve consensus on priorities within an era of very constrained resources. We must have this consensus in order to effectively act. Thank you very much for your attention.
We now have some time for questions, a bit more than half an hour, in fact. And I would, at this point, open the floor for questions. We will have roving mics, I'm informed, to make that a bit easier. I would just ask anyone who would like to ask a question to, first of all, identify himself or herself and any organization that you represent. I will try to collect a few questions and pass them over to my colleagues, but who would like to go first? The gentleman over there.
Good morning. I'm Samer Jabour from the Faculty of Health Sciences at the American University of Beirut, which is a small school of public health. So thank you very much. This was very insightful, and David, this was very moving, actually. Some of you must have watched the games last night, the football games, and it strikes me that the discussion on evidence and practice or evidence and policy is discussed always as a football game. The researchers throw the ball to the policymakers, and the policymakers throw the ball back. And this is the two-player game. It seems that the crucial player in this game, the absent player from the discussion, is what the European experiment is all about, the public. It is largely in the background, perhaps mentioned once in the three presentations. It's not there. And without accountability of those two big players to that crucial stakeholder, whoever you want, the reference point, I see very little progress in this issue that has been around for a long time.
Thank you. Gentleman up front here.
Hello, my name is Ben Cave. I work in health impact assessment, and I'm also a member of the International Association for Impact Assessment. Fascinating talks from the three speakers. Thank you very much indeed. We heard lots of calls for, I think from all the speakers, there was a call for us as public health advocates, devotees, researchers to get involved. We heard also from David Stuckler about the Machiavellian maneuvers that go on behind the scenes. I think also, you talked about food, you talked about tobacco and alcohol. You could go further. You could look at all forms of big industry. And certainly impact assessment attempts to work with and to put a case for environmental sustainability, for public health, for social impacts. But it is forced to work with business on that, and that might be good, it might be bad. So my question is working with industry always a bad thing for public health?
I have a request for the floor. The lady up front.
Thank you very much indeed. My name is Claudia Stein. I'm from the World Health Organization Region Office for Europe. And I must say I really appreciated the 3 presentations, and especially the link of knowledge translation. In the European region, we have really struggled with that. And when I say European region, I mean 53 member states, not just the EU, of the European region. In other WHO regions, there is a system called EVIPNet, Evidence-Informed Policy Network, which is hugely successful. These are workshops and platforms that bring together all stakeholders to identify policy questions, to identify the necessary evidence, and then create their own policy briefs. In Europe, we did not have that until 4 weeks ago, when WHO launched that in the Central Asian republics. And we find that the Eastern European countries and Central Asia are much more willing to embrace this approach. And this is really a call to Western Europe to help us to bring this also to the whole European region. It is so necessary, and the 2 speakers who spoke about that spoke from our heart, and thank you for that. So we'd like to really link with you, and we would like to link also with the European Commission to really bring this across Europe, because obviously it isn't working. Otherwise, why would we have seen these presentations? So thank you from the bottom of our heart. Let's talk.
Thank you. I can't see the back of the room very well from here, so if there are any requests for questions, could you please just let me know? Yes, there at the center.
I'm Raj Gopal from the University of Edinburgh in Scotland. Just like to make a couple of brief observations in light of the comments that have been made by the speakers. Firstly, if researchers and policymakers are to come together more, it does mean changing the nature of the academic job. Every hour spent alongside policymakers will be 1 hour not spent writing the next paper or the next grant or the next book. That's the only I'm teaching. In my